And Sachin, for those very warm words.
Thank you, sir.
And what you said was important, that most men with male infertility can be treated by IVF, but not all. I would say that most men should first be treated to improve their fertility and use IVF where it doesn't work, because otherwise we are putting the burden of the treatment on the woman who's normal. So we'll move on to the talk now. And I understand that we have quite a mixed audience with some people who are IVF specialists, others who do only basic infertility. So I'll try and keep the talk simple so that there's a message for everybody to take home. We will keep it very practical. Obviously, we can't cover all of male infertility in the time that we have. So I'll talk for about an hour or a little more, and then we can have question answers for a sizable period of time. So any doubts or questions that are not covered in the basic talk can be taken up then, because I'll go slow and leisurely and give enough time for the messages to sink in.
Thank you, sir.
This is a slide that I hope someday I will not have to show, because the slide says that the first step in the evaluation of an infertile couple is a semen analysis. And the sad reason why I have to show this slide is still, I see so many couples where the couple comes, the wife has a full hormone, 2 ultrasounds, HSG, this scopy, that scopy, everything done. And only then a semen test is done to discover that the male is azoospermic or is extreme oligo, which is not fair, because once you know that the male has a major problem, the entire evaluation protocol of the couple changes. So the very first meeting, when you're asking the wife to do her FSH and AMH and a few basic tests, you have to ask for a semen analysis. And nowadays, most men will cooperate. Standard precautions while doing the semen test: 4 days abstinence, wide mouth container, should not be contained in a condom or with lubrication. Now, the duration of abstinence, often I'm asked in meetings, what is the ideal duration? For the purpose of testing, the duration is 3 to 5 days, which may not be the ideal for that couple when they're trying for a pregnancy. For most couples, alternate day intercourse is better. For somebody with very, very low counts undergoing IVF, maybe 2 semen samples given on the day of egg collection, and the second sample with 2 hours of abstinence may be better. People, please be careful. Don't scribble on your screen, because then the slides get blocked. So you need to make sure that no annotations are allowed. So the ideal abstinence may vary from couple to couple. But for the purpose of testing, we said 3 to 5 days abstinence, because the norms have been established with a 3 to 5 day abstinence. The host, can you get rid of the scribble on the screen, because several of the letters are currently blocked by a scribble that I can see. One more scribble has appeared now. So you can just make it harder for the rest of the audience to see the slides. Now, when you ask for a semen analysis, now we have a red scribble and a gray scribble. Somebody is really busy with the scribbling. When you ask for a man to give a semen sample, bear in mind that some men find it hard to collect semen in the lab. So always check with them whether he'll be able to give a semen sample by masturbation in the clinic. And if he says, no doc, I can't do that, then home collection is fine. Even if he takes 40 minutes, 50 minutes to bring the sample from home, let him carry it in his pocket. And when he reaches the lab, he should tell the lab that 50 minutes are over, and that can be taken into account while assessing the sample. Few non-spermicidal condoms are available from those who supply IVF materials and media. And then, of course, we have penile vibrators, which can give strong stimulus to the penis. So men who have difficulty collecting a semen sample can actually use the vibrator to collect the semen sample. Now, how do we interpret the semen analysis? And this is important, because a lot of the labs are still using the old WHO parameters. And here part of the slide may be covered by the visual, but if you see the WHO parameters from 1980 to 200 to 2010, the sperm count, which was considered normal, has progressively dropped. Even today, I see many labs who will write normal count 60 to 150 million, which is very, very outdated. As per the latest WHO manual, normal count would be one with 15 million per ml, or a total count of 39 million, with a motility of 40%. So if a man has a count of 30 million, and the pathologist has written 60 to 150 million is normal, then that is obviously something to be disregarded, because the actual counts now, based on a statistical analysis, will be 15 million or more. Very important is the morphology. Now, in the past, we used to say that 70% sperm should be normal. Not true. Today, if you have a semen sample done in an IVF lab or a good lab, a report of 90% abnormal, 95% abnormal is perfectly fine. A lot of the time, the patient will come to me worried, doc, 90% abnormal. That means I'll be having a baby with two heads, or the gynec has told me that you'll have a very high abortion rate. Not at all true. By strict criteria, even fertile samples will have 95, 96% abnormal sperm, and that is not a cause for worry. So please be very clear about that. Depending on the lab, semen test done in a good lab, don't worry. Also very important to bear in mind is that semen fluctuates. These are 5 men who gave their semen sample every week for 1 year. And you can see that it is fluctuating more widely than the Nifty in these coronavirus days, shooting up below 8,000, over 9,000, up and down for no rhyme or reason. And this is important because very often a patient comes to me with 5 years of infertility with just one semen report. Where are all the other reports? No, the gynec told me latest report leke jao. Very important to look at all the reports, because only when you look at the trend over a period of time will you know what is the main semen parameter of this person. One semen sample may be normal, the rest will be abnormal, or vice versa.
Sir, sorry to interrupt you, Sachin here, sir.
Yes, Sachin.
Sir, on your screen there must be on the. Are you from the laptop or from the mobile or a tab?
On the laptop.
Sir, there must be an annotation button. If you
Yeah.
can just check that out, you need to press that button.
Yeah.
And clear. So all the scribbles will clear off.
Okay, clear.
What is
very good. Clear all drawings. Yeah. Okay, got it.
Yeah, so that is cleared off. So what you have to do is you have to as your mouse is moving,
yeah,
it is taking the scribbles. So
yeah,
just move that from the clear button, from the pen button to a clear button. So it will not come again.
I can't see a pen button anywhere, but anyway, right
Yeah.
now I'm not using the mouse. So how do I go back to the doc new share again?
So on the left hand side below is the back screen and the front screen progression. You can just move the cursor probably. Or if you are using the laptop keypad, you will be having the arrow keys on the between the numerical pad and the main pad. So you can use that to progress the slide.
Yeah, but now I'm not able to go back to my doc.
So you can just press escape and then again load the doc.
Okay. I'm not escaping either.
Escape is not happening?
No.
Has the annotation bar been stopped, sir?
Annotation is appearing next to pause share. If I click on annotate.
Or you can just probably close the presentation and start the presentation.
Okay,
again.
here we are.
Yeah.
Okay.
Yes, sir.
So now we're going to look good. That scribble on the screen was very bothersome. Thank you.
Yes, sir. Right.
So now let's look at, you've done a semen test, and how do you interpret the various parameters? As per WHO manual, count of less than 1.5 ml is low, but I've seen in many Indian patients 1 ml is their normal volume. So for our patients, I look at a volume less than 1 ml as low volume. Now, when a patient has low volume, you can have two situations: low volume but sperm present, so maybe 0.5 ml, 4 million sperm count. And when you see this, it should warn you that the sample has not been collected properly. Either there is a short abstinence, maybe he ejaculated in his sleep just before giving the semen sample, or there was spillage. So when I see a report like this, I would assume that it is not a true report and go back to another semen sample before giving an opinion. On the other hand, if he has low volume with azoospermia, and typically fructose would be absent in such a case, then 9 times out of 10, this is a case of CBAVD, congenital bilateral absence of the vas deferens. And occasionally there may be an ejaculatory duct obstruction. Now, this is very important to have this correlation, because I've seen men, they walk into the clinic, we look at the semen, and you think, oh, this man is vasoplasia. And 5 years have gone past. He has seen 10 clinicians, and the diagnosis of vasoplasia is not made. So when there is persistent low volume with azoospermia, the patient has to be examined properly, because most likely he has vasoplasia. Now, this is an entity that is always brought up in every question answer session. My patient has delayed liquefaction or increased viscosity, so what should I do? Unfortunately, you can't do much. And having said that, let me explain this a little more in detail. When semen is ejaculated, proteins in the seminal vesicular content cause coagulation. And then over the next half an hour, enzymes from the prostate liquefied. So within half an hour, it liquefies. And then you should be able to pour it drop by drop. So if it is liquefied, but it is viscous, and viscosity depends on the electrolytes and the proteins in the semen, then if it's very viscous, it won't fall drop by drop, it'll fall as a blob. In other words, liquefaction and viscosity both represent the secretions of the seminal vesicles and the prostate. And alteration in these are due to an alteration in the secretion of the prostate and the seminal vesicles, sometimes as a consequence of infection, either active infection, or even if there was a past infection, often the quality of the secretion remains altered. But in many cases, this is idiopathic and nothing that you do changes it. So you have a semen report that shows altered liquefaction or delayed liquefaction, a sample not liquefying, a sample very viscous. What do we do? One is, of course, look for other markers of infection. Are there pus cells? Is there a history that may suggest a urinary infection or epididymoarchitis? Or is the prostate tender if he's seen by a urologist? In such cases, yes, give him antibiotics for 3 weeks, 4 weeks, antioxidants. Sometimes if liquefaction is delayed, we'll add a liquefying agent like bromhexine. But if none of these are present, often this is just idiopathic and there is not much we can do. And often you will find that because the semen is not liquefied, the lab is not able to analyze it properly. So the first thing the lab has to do is push the semen through a syringe with a needle so that it is forcibly liquefied. If it's very viscous, then the semen count may not be proper because they cannot stir the sample properly. So it's very important that the lab deals with the sample correctly and then tells you what the sperm count and motility are. And if the semen is showing delayed liquefaction, increased viscosity, but the motility is good, probably this has no clinical consequences, and in vivo, within the woman's vagina, in her body, the semen will probably liquefy and the sperm will be released. And you can prove that by doing a postcoital test, which unfortunately very few people do nowadays. Now, if the liquefaction and viscosity is persisting across samples, if there is no pregnancy naturally, if there's no evidence of infection, you've given empirical antibiotics which are not really indicated, but still you give it and it has not helped, then the way to bypass the problem is give the patient 2 beakers, each containing 3 or 4 ml of media, and let him collect the semen as a split sample. The first squirt in one beaker, the second squirt in the second beaker, because the first squirt and the second squirt represent different secretions from the seminal vesicle and the prostate. And when it goes into the beaker with media and the patient immediately shakes it up, the semen sample will get diluted and therefore it will not coagulate. So the question of liquefaction and viscosity doesn't arise, and one can quickly harvest the sperm from that and use that for IUI. So this is how you would deal with the problem of altered liquefaction or increased viscosity. Now, many times you see impaired motility, and again, this is a spectrum of cases. You could have zero motility, you could have very poor motility, 5 to 10%, or you could have moderate asthenia, 30% motile but with normal count, or 30% motile with low count. And each of these is a separate entity. If there's total asthenozoospermia, no motile sperm at all, then you need to do a viability test to know whether these are live sperm which are immotile, in which case this is Cartagenous syndrome or another variant of that. And you can do ICSI using these ejaculated sperm because though they are immotile, they are live. On the other hand, if the eosin, egrosin or HOS test shows that these are all dead non-motile sperm, then for ICSI you will have to take testicular sperm. And amazingly, in most of these cases, the testicular sperm will be live, sometimes even motile, and can be used for a very successful IVF ICSI. Of course, always make sure that the sample was collected correctly. Every once in a while, total asthenospermia will turn out to be a sample collected by coitus interruptus, collected into a condom, and therefore they were all dead. If there is severe asthenia, 5 to 10% only motility, usually medical treatment will not help, and they will need IVF ICSI with the ejaculated sperm. If there is moderate asthenia, 30% motility but not very active, and low count, that is the case of oligoasthenoteratozoospermia, and you will treat them like an oligoastheno using all the measures that we will talk about later. If there is poor motility but good count of 50 million but motility only 20-30%, these are the patients you may want to treat with a mixture of coenzyme, carnitine, lycopene, etc. And some of them may improve. Now, if a man has a low count, you're looking at every possible cause that can suppress testicular function. A large proportion, you don't find any cause. It's idiopathic, but in many you will find either a varicocele or infection or past history of testicular trauma or a recent illness or other generalized problems which can be corrected. And we'll talk about those when we talk about management of oligoasthenia. Now, often the semen sample will be reported as showing agglutination. 1 plus agglutination doesn't mean anything. Occasional samples showing agglutination doesn't mean anything. Multiple semen samples showing a large amount of agglutination could indicate infection. So again, look for pus cells, semen culture, clinical symptoms. Could indicate antibodies. So this may be one of the very, very few cases where you would do a sperm antibody testing. And often it is idiopathic. Again, if agglutination is not treated with your antibiotics and antioxidants, one would go in for sperm processing and IUI or AIT. Now, a very important message, very, very often I will get patients referred to me for treatment of pyospermia, where the patient has been given extensive antibiotics, the pyospermia has not gone away, and then the patient is referred. Same with semen culture positive, antibiotic given, semen culture positive. And when we do the semen test or the semen culture again in the correct manner, neither do we find pus cells and nor do we find any growth on the semen culture. And the patient has undergone extensive unnecessary treatment. Very important to realize that most pathology labs will take a drop of semen, put it on a slide and examine the wet preparation under light microscope. In which case there are 3 types of round cells and they all look the same. There is the actual leukocyte which represents infection. There are also macrophages which are normally present. Their job is to eat up the dead sperm. And there are primary spermatocytes which are also normally secreted in the semen. All 3 look the same in an unstained slide. So you have to talk to your pathologist that if the round cells that you see are few, no problem. But if you're seeing a lot of round cells and you're reporting those as 15 to 20 pus cells per high power field, don't do that. Please stain the slide. Actually, according to the WHO manual, the pathologist is supposed to use peroxidase to stain the slide, and only the peroxidase positive cells are reported as leukocytes. And if those are present in a count of more than 1 million per ml, only then is the sample labeled as having pyospermia. 8 or 9 out of 10 samples that come to me with a label of pyospermia, when we retest the semen sample, we find that there's no pyospermia at all. So very important. So what do you do in your practice? Now that you're aware of this, talk to your pathologist. Ask him, how does he check for pyospermia? Does he just look at a wet prep? Does he stain the slide? If he's not staining the slide, please get a copy of the WHO manual. It's available online. If you write to me, I'll send you a free copy. And show him the manual that this is what you need to do, because otherwise you're going to be giving a lot of unnecessary antibiotics, some of which may actually harm the sperm quality to patients who don't need it. The same with semen culture. A lot of IVF labs will routinely do a semen culture. Actually, there's no evidence recommending that practice, but still they do it out of nervousness. And 8 out of 10 semen cultures that come to me, which were positive, turn negative when we collect it properly. So what happens is that a lot of men who are uncircumcised just masturbate, collect the semen sample, and that is contaminated. So when you ask for a semen culture, a man has to carry betadine solution and a bottle of boiled water with him to the lab. He needs to clean the penis with the betadine, pull back the skin if he's uncircumcised, clean the glands with the betadine, leave it there for 5 minutes. Meanwhile, he should pass urine so that the bacteria and the anterior urethra are washed away. Then with the boiled water or the saline that he's carrying, he washes the glands, washes the penis, washes his hands. Then he may take the skin forward, and then he masturbates and collects a semen sample, with the semen going directly into the bottle without putting the penis in the bottle. And in an amazing number of cases, positive cultures will turn negative. So this is very, very important to bear in mind in your evaluation of the baby. And finally, in the semen sample, often you will see teratozoospermia, 70, 80, 90% abnormal. Don't panic. As I said, most often this is just due to the lab becoming stricter and stricter. Rarely it may indicate that the patient is exposed to some kind of gonadotoxins. So at this point, again, a scribbler is up here. Do I need to go to another? It went away. Are there any questions that the host would like to ask me about the semen testing itself? Then I'm going to move on to history and examination.
Sir, I would like a brief answer about the postcoital test. Still, you think that postcoital test is of utility?
So the reason why I believe in the postcoital test, while the gynecologist who should be doing it doesn't, is for a good postcoital test, what are you doing? You're monitoring the ovulation. You're looking at the cervical mucus. You're seeing whether it is in sync with the ovulation. In the process, you're picking up cervicitis, which is often very common. Then at the time of intercourse, you're checking for sperm. If sperm are not present, but the semen analysis is good, it tells you that there's a problem with coitus. If there are sperm, but you find that they are not able to penetrate the cervical mucus, it picks up sperm antibodies, which otherwise you don't pick up because you don't have the correct test of it. So a lot of things get looked at. It's not just the simple PC turn. Now in Western literature, they said the postcoital test is not required because it doesn't predict outcome. But it's not just a matter of predicting outcome. It's looking at all these parameters that we talked about. Everybody will do an ovulation profile, but if you add these, looking at all the other things, then therefore I think it's useful.
Sir, somebody is asking, what is the dose of steroid if at all agglutination test is positive? I mean, sperm antibody test is positive.
So both for antibodies, okay, I'm going to come to investigations where I'll tell you about antibodies.
Okay, sir.
Because most people, when they talk of antibodies, they're diagnosing it on the basis of an ELISA test, and I need to comment on that. It's a relevant question.
Okay,
So
sir.
let's move on then.
Yes, sir.
So patient has come, you've asked for a semen test, you've done it, you've interpreted it. Now what do you do? Ideally, you need to take a history and examine the patient. Most of you, unfortunately now, Dr. Rajesh, Dr. Sachin, you will examine the patient, but a lot of lady gynecologists, unfortunately, feel inhibited. I don't know, somehow it's just been the training that lady gynecologists don't. Lady urologists poke their fingers in the rectum very aggressively, and the men don't seem to mind it. So ideally, everybody should examine. But even if you're not examining them, a good history important. Start with the sexual history. About 5% of male infertility, or rather couple infertility, is due to a sexual problem. Infrequent sex, incomplete penetration, use of the long lubricant, wife washing immediately, something that would show up on the postcoital test and could be picked up from the history. So very important. It's sad when you have a couple coming to you who've already tried IVF once, which has failed, and you discover that actually the marriage was never consummated. That need not happen. Personal history. Again, more and more evidence accumulating that the lifestyle makes a big difference. I have men who come to my clinic 3 months later, and the second semen report is very good. And I'm surprised. I asked them, what do you do? They said, Doc, no, you told us to take care. So I've stopped smoking, I sleep better, I started exercising, I eat good vegetables, and boom, sperm count jumps up. So look into their history, dietary habits, sleeping patterns, stress, sauna, steam. And now, unfortunately, a lot of men are trying to get muscular. And in the gym, they're taking a lot of whey protein, and we're not sure of the quality of the whey protein. Some of them are being given steroids by trainers who don't know. Recreational drug use of charas, marijuana, very common, and that affects semen quality. Cigarettes more than 5 to 10 a day. Mobile phones, people will ask me now. It's a fact of life. You have to use the phone, but at home we tell patients keep it away from you and not in your pant pocket. So all these things could make a difference and if picked up. Then there is also specific history based on the semen. So if the semen has shown azoospermia, you want to ask whether there was history that could have led to testicular damage, because that takes you along one line of investigation. So mumps, orchitis, undescended testes, or what is history that suggests obstruction, hydrocele surgery, hernia surgery, STD, all of which would make you think of obstructive azoospermia. If only the motility is poor, is he having repeated respiratory tract infection? That would suggest a defect in the sperm tail. Such patients will not improve with whatever medical therapy you give them. Or does he give a history of repeated urinary infections, burning, dysuria, such as a man who with antibiotics may do very well and the motility may improve? Or is it oligoasthenia? Then you go into the whole general history that we already spoke about. So based on the semen parameters, you can direct your history to try and pick up the cause. And examination. Now, of course, I would like to say, please, please, please examine the patients. Many of you still won't. Then at least be friends with a surgeon or a urologist so that everyone gets examined. Because too often gynecologists use ultrasound as a substitute for a physical examination, and that does not work. And I'll talk to you more about that. For those of you who are examining, how do you learn how to examine the male? Start by examining all men who have normal sperm counts and try to feel the testes, go above and behind the testes, try to feel what a normal epididymis is like, its fullness, its turgidity, its tenderness, and try and trace it down and behind and feel the vase and the cord. In the beginning you won't, with time you will. And one very useful tool, if you are examining the patient, is the Prader orchidometer. So you compare, you feel the testes in one hand and hold the orchidometer in the other and see which bead matches the testes you're holding. One, of course, it gives you the volume, which is useful in reaching a diagnosis, but very important, it helps you counsel the patient. So if I have a patient with testicular failure and he has a small testes and I match the beads, I show him, see, I'm matching the beads, and then I show him the 5 ml bead, that this is the size of your testes which I'm matching. Then I show him the 20 ml bead, that is the size that we wanted. And that is the reason why you don't have sperm. It's much easier for the man to accept why he has azoospermia or a count of only 0.1 million. and the counseling for the next line of therapy becomes very easy. Now, this is available online, not now, of course, there's a lockdown, but otherwise on Amazon was available, severely overpriced. It could also be available much cheaper from other sites, but you can get it. So examination and history, very important. Having done that, how do we evaluate these men further? Should you be doing a hormone assay for everyone? And the answer is no. If the count is more than 10 million, all hormones, FSH, LH, testosterone will be normal. And therefore, it's a waste of money. If the count is less than 10 million, and definitely if it is less than 5 million, then you may want to do a hormone assay. And what you should be doing is an FSH, LH, and testosterone, maybe estrogen. And I emphasize this because by reflex, most gynecologists will ask for FSH, LH, prolactin, which is what you ask for in the woman. And that doesn't work for the male. In male, prolactin does not contribute to his infertility. So not important. But testosterone is very important for the interpretation of FSH and LH. TSHS you should ask for because hypothyroidism is getting more common in men. D3, B12 pandemic, one might say, in terms of their deficiency. And some evidence that there are D3 receptors in the testes and B12 may make a difference. So if they're abnormal, we'd like to correct them. But let me emphasize FSH, LH, testosterone a little more. So here are two men, both with the same levels of FSH and LH, both looking quite low. So you get this FSH, this LH, and you think, aha, here is a guy I want to give gonadotropins or I want to give clomiphene, etc. And then you do the testosterone, this is what you find. One man has low testosterone and low FSH, LH testosterone. And the other man has high testosterone. And because of the high testosterone, due to feedback, his FSH and LH are low. So the guy to the left needs hormone therapy because his FSH and LH are low despite low testosterone. And the guy to the right does not need hormone therapy because his testosterone is excellent. The testes is very well stimulated. So whether FSH, LH are significant or not is interpreted in the light of the testosterone. Now, in some cases, more than the testosterone, estradiol may be important, but some people go too far. They ask for all these tests. This is too much. The free testosterone, DHE, etc., don't matter. Estradiol only if the patient is obese. Some people ask for too less. What we really want is the FSH, LH, and testosterone, and sometimes estradiol. If the patient is very obese and estradiol is high and testosterone is low, that is the patient whom we can treat with an aromatase inhibitor like anastrozole 1 mg every alternate day. Now, what about antibody testing? The problem with antibody testing is that most of the people have access to only ELISA tests for antibody testing. So ask your pathologist, how are you looking for anti-sperm antibodies? And if he's doing an ELISA test on the serum, it has no clinical relevance. Antibody titer in the blood does not correlate with antibodies on the sperm. And the ELISA test in particular has antibodies to all kinds of irrelevant antigens. So positive ELISA has no role. And that's why when somebody asks me that there's agglutination, antibody test positive, should I give steroids? Irrelevant if you've done an ELISA test. The actual test is the immunobead test or the MAR test, which require at least certain counts and certain motility for them to be done. Very expensive, not easily available. And I've seen only very few, 3 to 4% of the tests coming positive. And actually the treatment too is not very effective. So steroid, what is the dose? 5 mg of prednisolone for 20 days, then taper it, or 10 days. 5 mg 3 times a day for 10 days, then twice a day for 10 days, once a day for 10 days. Do not give high doses of steroids. In the past, we used to give 60 mg of steroids. There's a risk of avascular necrosis of the femoral head, and the benefit is unpredictable. So steroids may help, but if at all, low dose, not high dose. Now, because ELISA is not reliable, immunobead and MAR test are not available, once again, the PCT becomes a useful screening test. If you have a good semen analysis, good cervical mucus, but the sperm are not penetrating the mucus, you've picked up antibodies either on the sperm or in the cervical mucus, and you know that this couple needs IUI, no point in wasting time trying for a natural pregnancy. So that is the reason why I say no antibody testing. What about routine ultrasound testing? As I said, most gynecologists tend to use ultrasound as a substitute for clinical examination, and it is not so. In fact, it can be misleading. Now, a joint statement by the American Urology Association and the ASRM, Society for Reproductive Medicine, both stated that only palpable varicoceles cause infertility, and ancillary measures, which means ultrasound, should not be used for the detection of a subclinical varicocele, because that subclinical varicocele doesn't need treatment. So what happens is the gynecologist has not examined the patient, sends the patient for an ultrasound. Detection of subclinical varicoceles is very high. Half the patients will come back with varicocele seen. Now the patient is stressed. The gynec doesn't know what to do. You send the patient to the general surgeon, urologist. He is no better. He says, varicocelar ultrasound, let's operate. It doesn't help the patient. For most cases, a good clinical examination, if no varicocele is seen, there's no point in doing the ultrasound. Testicular volume is assessed by the Prader orchidometer. Small epididymal cysts, which are often picked up on ultrasound, are of no clinical relevance. We would do the ultrasound only if you've already clinically picked up a varicocele, you want confirmation, you're planning surgery, you need to show the patient, okay, you have a varicocele. Or some men have a very tight scrotum, examination is not proper, we can't examine the cord, or you're not sure whether the testis is palpable, or you're planning sperm retrieval in an azoospermic male. Then before doing a TISA or micro TISA, you need to rule out a tumor. So ultrasound has a very limited role, and it is not a substitute for a good examination. So please let that sink in. Now, what about diagnostic testicular biopsy? In the past, used to be routine. Azoospermia referred to so-and-so for biopsy, and vasography, often complete nonsense. Or count of 1 million not responding to medical therapy, refer for testicular biopsy. There is no role for testicular biopsy in oligoasthenozoospermia. If a man has 0.1 million sperm, he needs IVF ICSI, the biopsy will not change anything. Even in azoospermia, only some men require a testicular biopsy, and that too nowadays, the diagnostic biopsy and the therapeutic biopsy are combined. Usually it will be more than one biopsy. It will be multiple biopsies. It won't be a conventional open biopsy. It will be a needle biopsy or a mapping biopsy or a microTSA. One sample may go to the pathologist, other samples will go to the IVF lab. So the whole concept of testicular biopsies has changed dramatically. And if you have time to discuss azoospermia, which I doubt, then we'll talk more about testicular biopsies. So what about other tests? There's a lot of pressure on the gynecologist by my computerized semen analyzer, CASA. A well-trained semenologist, a well-trained lab person will give you the same clinically relevant information as CASA. CASA, sophisticated CASA, expensive CASA, can give you additional data like curvy linear velocity, etc., etc. Those are very useful as research tools, but from a clinician's point of view, a properly done semen test is actually sometimes better than the computerized analysis, because when there are very, very few sperm in the semen, which can make a big difference in the management, the CASA may actually fail to pick it up. The same holds true for morphology. Unless you're going in for a very expensive machine with a very expensive software, you may not pick up morphology. So the common misunderstanding is CASA will bring complete automatization. I'll save time, or I'll save money, or I'll be more accurate. Not necessarily. To use CASA well, you need a well-trained technician putting in a lot of time, combining the automatization with the manual method to then give you a very good reading. So for the clinician, not really relevant. What about the other sperm function tests? Beautiful sperm function tests, but not clinically relevant. The only test that is relevant is the sperm DNA fragmentation testing. Now, the original test done 20 years ago by Everson had quite dramatic data. Everson stated very unequivocally, if the DNA fragmentation is more than 27 or 30%, there'll be no pregnancy, irrespective of the routine semen analysis. And if DFI is low, there could be a pregnancy, even if semen parameters are poor, which made it seem that DNA fragmentation should be the first test, maybe the only test, and it should replace conventional semen analysis. Unfortunately, as we went along, we realized that there is too much of variability. There are a whole range of tests. Patient may test positive on one, negative on the other. I've had the same patient, 91% DNA fragmentation in one lab, 17% DNA fragmentation in another lab. Intra-patient variability, inter-lab variability, inter-test variability. And the fact that there's no definite cutoff. Sometimes even with the DNA fragmentation, which is very high, there'll be a natural pregnancy. And in many cases where nothing else is found, DNA fragmentation also is normal. As a result, though it is a test which probably has a good role, as of yet, it should not be a first line. It's expensive if done correctly. And the information is still not reliable enough. So if you're a good, big IVF center, certainly do it, but do it almost as a research protocol. After doing 100 tests, look at your results, that in your lab, with the test that you are using, is it relevant or not relevant to your clinical practice? Current clinical recommendations would be idiopathic infertility, where you don't know why pregnancy is not happening. Then you may do a sperm DNA fragmentation, and if it's high, you're moving towards ICSI. Or if you've done ICSI a couple of times and there's been no pregnancy or an early pregnancy loss, then you want to look at DNA fragmentation, and if it is high, then in fact, we may often take testicular sperm and do ICSI for such patients. So limited role, and you must review your results. Don't just blindly do DFI for everyone. Reactive oxygen, interesting. In fact, there's currently a move to reclassify oligoasthenozoospermia as idiopathic when nothing is abnormal, and those with raised ROS, where it is the raised ROS that is the cause of the oligoasthenia. But as of yet, this is still experimental. The test is not easily available, highly expensive, so not relevant to those of you who are listening today. Finally, what about the other tests? Genetic testing, not for everybody. And you have to be specific. Remember that in a man with vas aplasia, you're looking at a cystic fibrosis mutation. In a man with testicular failure, you're looking at a YQ deletion or karyotype. I keep on finding patients where a cystic fibrosis and karyotyping has been done, and he has testicular failure and cystic fibrosis CFTR mutation test. They're expensive tests. You do a full CFTR panel that will cost the patient 25,000 rupees. So the test has to be specific and well thought of. Semen culture, we already spoke about, has to be done with precautions. Vasography, no role in this day and age because it's replaced by the transrectal ultrasound. So this is how we evaluate the infertile male. And before I come to management, again, I'll pause if there are any questions that could be asked from the host because it's already 3:47. So we have very little. We'll take a few questions, quickly complete oligoastheno. And yeah, we need to finish by 5 o'clock. So we have some time as well.
Yes, sir. So somebody is asking, do you think the reference value of WHO 2010 reliable more than 1999?
Okay, when I talk on oligoastheno, I'll show you data suggesting that semen analysis is only 60% accurate. How did 2010 parameters come about? They studied 1,500 men, single semen sample, who had achieved a pregnancy in the last 1 year. In the study population, all of India, all of Africa, most of Asia was excluded. So the data is more relevant to the Western population. But it was a statistical analysis. The cutoff that they've given is the 5th percentile of the fertile population, which means 5% of those who achieved a pregnancy had sperm parameters below the 2010 parameters. But it also means that if you look at the 50th percentile, then of course the average sperm count of a fertile man is much more. But if you have to choose between the earlier parameters, 1999 and 2010, you would go by 2010 with a lot of reservations, which I'm going to talk about in the next part of this talk.
Sir, semen culture is indicated for all pyospermia. That's another question.
So if you have pyospermia, first thing is to confirm that it is genuine pyospermia. 80-90% of pyospermia will get ruled out when you do the correct test, which I've already explained. If it is persistent pyospermia, then I initially give these patients a course of doxycycline for 15 to 20 days to take care of chlamydia and mycoplasma, because those are common infective agents and they don't show up on the semen culture. After that, I will redo the semen. If pyospermia is still persisting, then only do I do a semen culture and then give antibiotics as per the culture.
So according to you, sir, there is no role of empirical antibiotics. Somebody wanted to ask.
A lot of people do it, IVF specialists do it, others do it. But whatever data is there, published studies have been done, trials have been done, they don't really justify the use of empirical antibiotics. Now, if you're practicing, say, in an area where the incidence of cervicitis is very high, every alternate woman you're seeing has cervical erosions. Maybe there, if you're treating the wife empirically, you also want to treat the male at the same time. But if there is no evidence of infection in the wife and no evidence of infection in the semen, then giving antibiotics to that couple is meaningless.
Can we get normal DFI in severe OAT samples, sir?
Of course you can. You can get normal DFI. That's why it's a waste. I see often man with 1 million count, 5% motility referred for DFI. Irrelevant. That man is going to go in for IVF ICSI. And irrespective of his DFI, your first ICSI is not going to be testicular sperm. It's going to be the ejaculated sperm.
So what is a mapping biopsy?
There are two types of mapping biopsy. One which is popularized by Paul Turek in azoospermic men, which I think is a very, very wrong thing to do. And the other kind of mapping biopsy is a therapeutic biopsy in azoospermic men, where multiple biopsies are taken from all over to retrieve sperm for IVF ICSI. So this is something that we could talk about in detail if we have a session on azoospermia at a later time.
Okay.
But it's meant for azoospermia.
Sir, is it mandatory to do USG of testes for all TSA patients? TSA patients?
I don't actually do it for all patients, but theoretically it's mandatory simply because the incidence of, again, it's if you're doing a test for obstructive azoospermia, not mandatory. If it's a testicular failure patient where there's a history of mumps orchitis, not mandatory. But if it is a case of testicular failure, primary, with no evidence of anything that has damaged the testes, theoretically, these men are more prone to testicular tumors. The incidence is still less than 1 in 1,000 or 1 in 10,000. But that one case in your practice, you do a TSA and somehow it turns out to be malignancy, then you're in trouble. So if you're doing a needle biopsy, probably it doesn't matter because you're not likely to hit the tumor. But if we are planning a micro TSA where we're going to cut open the testes, there it would be safer to do an ultrasound before doing the micro TSA.
So total or free testosterone? Normally, when you advise test?
You should do total testosterone. Good question. The reason why you don't do free testosterone is that all labs are doing free testosterone by a radioimmunoassay. And a radioimmunoassay of free testosterone is very unreliable. So even when we want to look at free testosterone, we will measure total testosterone. We will measure SHGB, sex hormone binding globulin, SHBG. We will measure albumin and use a formula to calculate the free testosterone, because the calculated free testosterone is more reliable than a RIA. So from your practical purpose, look at total testosterone.
Sir, after the correction of lifestyle disorder, lifestyle like smoking, tobacco, or other things, obesity, takes how much time to improve the sperm parameter?
So one spermatogenic cycle is 60 to 72 days. So normally we tell the patient come back after 3 months. And when we talk of medical treatment for oligoasthenia, I'll highlight the same point that any medical treatment should also be given for 2.5 to 3 months before we judge whether it has worked or not. So let's move on to oligoasthenia
Yes, sir.
and
Yes,
then
sir.
come on to more questions.
Okay, sir. Okay, sir. Thank you, sir.
So everybody is waiting because this is the commonest patient you have in your practice. Large number of patients with low count, low motility, and you don't know what to do. So the only reason why we have 320 people listening is they want to know what treatment to give oligoasthenia zoospermia. What is that magic treatment? 312, 8 people have gone to FT. Okay, so the problem is that there is actually not much that you can do for many patients of oligoasthenia in terms of treatment, but there can be a lot that you can do in terms of planning the treatment. So all these questions and steps that you see listed in the slide need to be considered when you manage oligoasthenia. So the first question you ask is it genuine oligoasthenia? So there the question, which parameter will you use? If you use the 2010 parameter, a sample may be normal. If you use the 1919 parameter, it may be oligoasthenia. Was it done in a good lab? The same semen sample sent to 3 labs may show very, very, very different parameters. Was there a collection error? Did he have recent fever because of which the count has gone down? All these need to be looked at. So good lab, reliable testing, multiple reports before you label it as oligoasthenia. We already saw this slide highlighting the fact that you need 2-3 reports over a period of time before you can label it as, okay, very severe oligo, moderate oligo, mild oligo. Now, this is very important. Despite all that, bear in mind that semen analysis is only a rough indicator of whether a man is fertile or not. Some data to prove that in this study, which I've been quoting from the very beginning of my lectures because it's such an important study, of young couples recently married, trying for a child for the first 3 years, they found that the semen analysis was not predictive of who would get pregnant, showing that in young couples with a short trying time, very often a super fertile wife could compensate for the subfertile male. And all the gynecologists are nodding, saying, yeah, men always get compensated for by women. So true, especially in young couples. Similarly, our parameters themselves are suspects. So in this study, 1/3 of fertile men had subnormal parameters. And in another study, a large number of infertile couples had fertile parameters and vice versa, with a huge overlap between the fertile and infertile groups. This was a very interesting study. Couples who had undergone ICSI for severe oligo, less than 1 million count. IVF failed. For 1 year, they did not do anything. During that 1 year, 6% of these couples achieved a spontaneous pregnancy despite the sperm count being less than 1 million and there being no helpful neighbor. So what all this tells us is that there is more to fertility than just the sperm count. Now, here's another very old study, but a brilliant study, therefore I quote it, which shows that if you take a man whose motile sperm count is only 1 million, very low, but who has been trying for a pregnancy only since 12 months, short duration of infertility, there is still a 25% chance that he could achieve pregnancy. The couple could achieve a pregnancy. So even with very low count, but short duration of infertility, the prognosis is not bad. On the other hand, even if the count is 20 times better, 10 million plus motile sperm, so very good sperm count. But the infertility is for 96 months, 8 years. The chance of pregnancy is only 14%, which means that time is a major filtering factor. Those who are going to get pregnant will do so in the first 2, 3, 4 years. And those who are not going to get pregnant will keep on trying irrespective of the sperm count. And therefore, when you're truly trying to assess whether a couple with oligoasthenia is infertile due to the male factor, to look at all the semen reports, the duration of infertility, the duration of trying, and whether the female was fertile or not, and then reach a judgment. If the wife was anovulatory, maybe just correcting that would achieve a pregnancy, even though the man's sperm count is only 10 million. So I have two types of gynecologic friends. Some who send me the mail and saying, Rupin, only after the sperm count improves will we treat the wife. And other friends who say, Rupin, I know you're too busy. We're not going to send you the patient. We're just going to treat the wife and forget the male. Neither approach is actually correct. Don't wait till the male improves before treating the female. And don't treat the female without trying to correct the male. If both are treated simultaneously, that is when you will have the best possibility of a pregnancy, because 2 into 2 could be 4, or 4 into 1 could be 4, or 1 into 4 could be 4. Now, equally relevant in our decision making is knowing whether there is a correctable cause. Because if there is a correctable cause, we're not going to rush into IVF. We would want to correct all these factors and see whether we're able to improve the semen. And there could be varicocele, filariasis, funiculitis, systemic illness, irregular health, multiple exposure to gonadotoxic, and all of these, if corrected, may help the patient. Equally important is to find out if there are irreversible causes. And this is important. Man comes to me, his sperm count is 2 million, and there's a history of bilateral orchiopexy at the age of 5. According to me, he's lucky to have 2 million. I'm not going to waste time giving him medical therapy. That 2 million will disappear with time, and I will tell him, go up for IVF right away. Or if he had mumps orchitis and he has sperm, or if he had testicular torsion, or I examine him and the testes are only 8 mm, less than half the normal size. FSH is already above normal. And he still has 1 million sperm count. He's lucky to have that 1 million. We should not be wasting time trying to treat this male. So based on the history of the reversible and the irreversible causes, and the examination findings and the investigations, we then plan the treatment. DNA fragmentation, not as the first line, only later on if IUI has failed, IVF has failed, or ICSI has failed. So typically, these are the indications for doing DFI. Similarly, oxidative stress, in future, maybe we will be measuring the reactive oxygen stress before prescribing antioxidants, but currently these methods are too expensive and not available. So keeping all that in mind, how do we treat patients? So here are two couples. Sperm count is the same for both of them. 10 million sperm count, 30% motility. But the couple to the left is young, trying time is short, they've not had any medical therapy. Certainly this is a couple who does not have to rush into IVF, and he could take medical treatment for another 3 months, 6 months, 12 months before we decide they move on to the next level. The couple to the right, same sperm count, but already married for 10 years. He's taken medical therapy. His file is so thick. Just because he has come to me for the first time doesn't mean I give him another 3 months of treatment. This couple should not waste any time. We need to go in for IVF ICSI right away. So only after looking at the totality of everything, we decide which oligoasthenia needs treatment and which does not. Now, what treatment options do we have? True hypogonadotropic hypogonadism will usually present with azoospermia rather than oligo, but there can be a relative hypo-hypo, where FSH, LH, testosterone are all normal but low normal, and such people can be treated, and we'll talk about how to treat them. In our population, chronic filarial epididymal orchitis in certain populations give them antifilarial and low-dose steroids, and they can be quite a remarkable improvement. If there is a proven infection of the prostate and seminal vesicles, long-term antibiotics for 3 or 6 weeks may help improve the semen quality. Anti-sperm antibodies, as I said, the diagnosis is tricky, therapy is tricky. You may give low-dose steroids or plan IUI. Some men will come to you if you've examined them. The scrotum is very thick due to chronic dermatitis, very common in Bombay, for example, due to the hot, humid weather. We give them antifungal treatment. The skin improves, the temperature drops, and they do much better. Now, varicocele, to treat or not to treat. The urology textbook says that the varicocele is the commonest correctable cause of oligoasthenia. Many gynecological textbooks says that there is no role for varicocele surgery. We don't have time to go into the full controversy, but let's start by saying that varicoceles have varying impacts. Many men with varicoceles are perfectly fertile with normal semen parameters and many children. In many cases, after a varicocele, the semen parameters may have reduced a little, but still don't affect fertility. Sometimes the semen parameters may fall significantly, but still the wife is fertile and so they achieve a pregnancy. In varicocele is very common. So in some cases of oligoasthenia, a man may have oligoasthenia and a varicocele, but the varicocele may be coincidental and not the cause of the oligo. So in other words, there are only some men with oligo and infertility and a varicocele. And these are the men who can possibly benefit from varicocele surgery. So what is the clinical guideline to follow? The first is don't do an ultrasound to look for a varicocele. Varicocele should be a clinical diagnosis. Once a varicocele is diagnosed, then we can do ultrasound to confirm the varicocele, to check the other side, to decide how severe and to plan the surgery unilateral or bilateral. I will usually diagnose the varicocele and tell the patient, look, you have a varicocele, we can operate, 50-50 chance you will improve. Or you can try medicine for 3 to 6 months, and if you don't improve, then we will operate the varicocele. A lot of men opt for medical therapy, and surprisingly, 25% of them improve while on medical therapy, achieve a pregnancy, and the varicocele is never treated. If they come back after 3 months, 6 months, no improvement, then we tell them, okay, we'll go ahead for surgery. It's a 50-60% chance that there will be significant improvement. If we do operate, the preferred method is microsurgical varicocelectomy so that we can identify and preserve the artery, identify and preserve the lymphatics, and tie off every other vein so that the recurrence rate is lower. Laparoscopy can be done, but not the best way to treat a varicocele. And who will improve? On an average, 2 out of 3 will improve. Pregnancy rates will depend on what was the initial sperm count. If somebody had a count of more than 10 million and we operate the varicocele, we expect 2 out of 3 couples will achieve a pregnancy because of the varicocele surgery. If the count was less than 5 million and we operate, 1 out of 3 will achieve a pregnancy. So it's useful, but it's not absolute. Now, if we don't find any cause, there's no varicocele, no gonadotoxic factor, lifestyle has been corrected, how do we go about giving empirical therapy? Which one is the best? Lots of treatments are available. Zinc-containing multivitamins, simple antioxidants like lycopene, vitamin E, expensive antioxidants like coenzyme Q10, carnitine combinations. We have hormone therapies like clomiphene, tamoxifen, anti-estrogens. We could use gonadotropin injections. We never use injectable testosterone, but you could use oral testosterone, which doesn't depress sperm counts. And we have herbal preparations. So how do we navigate through these maze of therapies? What does the evidence show? Now, the evidence shows that giving antioxidants, and this is a Cochrane database review, may improve live birth rates, but the level of evidence is still low. Which antioxidant is superior? We cannot say. Which antioxidant combination is superior? We cannot say. But there could be some role for antioxidants. To give or not to give will depend on many things: age, duration, semen parameters. Somebody with 1 million sperm count trying for 10 years, we don't want to waste time. But a young couple, short trying time, we will give some form of empirical medical therapy to buy time. And during this period, perhaps we will improve the semen parameters, and perhaps many of them will achieve a pregnancy. But older couples, more than 30 or 35, 5 to 10 years infertility, very low counts, there we don't want to waste time. We'd like to just proceed as soon as possible. Also bear in mind that since no therapy is proven, we don't want to treat with something that is too expensive if a patient cannot afford it. So what is my practical approach? If I have a patient from a poor socioeconomic class, I will give a simple, inexpensive multivitamin that will cost him 10 to 15 rupees a day. That's already a lot of money for him. And surprisingly, a lot of them come back with improvements, suggesting that there was a genuine nutritional deficiency that got compensated. So I'll give them a zinc-containing multivitamin plus one lycopene tablet plus one vitamin E tablet. All of them together are still not expensive. If the patient can afford it or has already tried the multivitamins, then I may try the more expensive combinations that contain coenzyme Q10, carnitine, but bear in mind that it can cost the patient anywhere from 50 to 150 rupees a day, depending on the dosage. And of course, lifestyle change, exercise, diet, all that important. Now, this is for patients with mild to moderate, so more than 5 or more than 10 million, these things can be tried. If they come back after 3 months with a new semen report, so I give it to them for 3 months, and if they haven't improved, then I will switch to another combination. And if there's still no improvement, then we change. Now, this is the wrong prescription. Here is a prescription given for 30 days. 30 days, not enough to produce improvement. And very often the patient comes back, see, I took it for 30 days, this is my semen, I've not improved, change my medication. You have to give it for 3 months, and the patient has to come back after 3 months with the semen report. And we explain to them that it takes 3 months for improvement, and therefore you need to take it and then do the semen test, because if you have improved, I will continue the same medicine. But if you have not improved, then I need to change it. Different medicines, can you use provironum? Yes, provironum can be used. We use it as a second or third line. If other medicines have not helped, though it is a testosterone, it does not suppress FSH and LH because it is in the form of mesterolone, which cannot get aromatized to estrogen, and therefore it does not suppress the HPT axis. What else? Now, if the counts are less than 10 million, we mentioned earlier that we would do FSH, LH, and testosterone. If the testosterone is more than 400 nanogram per deciliter, that means that this testis is well stimulated and no hormone therapy is indicated. If the testosterone is low, which means below 300 nanogram per deciliter, 3 to 400 is the gray zone. If it's less than 300 nanogram, then we look at FSH, LH, and estradiol. If testosterone is low and FSH and LH are high, that indicates testicular failure. Hormone therapy will not help. Second, testosterone is low. FSH and LH are also on the lower side, 2.3, 3.2. They should have gone up, but they haven't gone up. This is the case where there might be a relative hypogonadotropism, and stimulating the testes may help. You can stimulate with HCG alone, HCG plus HMG, or clomiphene or tamoxifen. Clomiphene is the cheapest option, 25 mg once a day. You can give it once a day, alternate days, 50 mg twice a week, 25 mg for 25 days and stop for 5 days. The various protocols, none is proven superior to the other. You can use any of them for 3 months. I often will check whether testosterone has gone up or not on clomiphene. If the testosterone has not gone up, then either I increase the dose of clomiphene or add HCG. If the testosterone goes up from 300 to 500 or 600, that means that the testis is now adequately stimulated, and then we wait and see whether the sperm parameters also improve or not. In some cases, the testosterone may be low, but the estrogen may be very high. So for example, a scenario like this. This is a patient with testicular failure, rare sperm in the semen, FSH is already very high, indicating testicular failure. testosterone is low, only 266, but estradiol is at the upper limit of normal, 37. And when you divide testosterone expressed in nanogram per deciliter, divided by estradiol expressed in picogram per ml, normally that ratio should be more than 10. If that ratio is less than 10, as in this case, then this is the patient whom we can treat with an aromatase inhibitor that will lower the estrogen, raise the testosterone, further raise the FSH and LH, and maybe stimulate the testes and produce slightly better sperm. So we'll give anastrozole 1 mg on alternate days, or letrozole 2.5 mg on alternate days. You could instead give gonadotropins, but they're more expensive, that's all. Sometimes you find isolated deficiencies. FSH is very low, LH is normal, testosterone is normal. There you may want to give HMG, or the other way around. FSH is high, but LH is low, testosterone is low. There you may want to give HCG with clomiphene. If there is isolated asthenozoospermia, and it is severe, 5%, 10%, medical therapy doesn't help. If it's 25, 30%, 40%, we can try CoQ, carnitine, antibiotics, low-dose steroids. Sometimes it helps, but try it for 2 to 3 months, and if it doesn't improve in that period of time, then don't waste more time. Now you've given medical therapy. If the patient benefits, continue the therapy and make sure the wife is optimally fertile. If in 3 months it doesn't help, switch to another therapy, again reassess after 2, 3 months. But have a timeline, don't go on forever and ever. In 6 months, 9 months, 12 months, there is no pregnancy, move on to the next thing, which could either be IUI or IVF. Now, some people have the misconception that IUI is a wonderful way of treating male infertility. Surf excel, dal do ho jayega. Doesn't work. IUI is a very inefficient treatment for pure male factor infertility. So in this study, the pregnancy rate was only 8% per cycle, and that too provided the initial sperm count, total count was at least 10 million and 30% were motile. But if you had count and motility lower than that, the pregnancy rate was no better than the chances of spontaneous conception, which was 3% per cycle. The same holds true if you look at the harvested report, at least 1 million. Many centers prefer 3 million or 5 million. So a common misconception that many gynecologists have is that, oh, let us try, even if it's 1 million or 2 million or 3 million, let's try. IUI is inexpensive. There's no harm done. There is harm done. If you don't meet the minimum parameters post-wash, you're wasting the patient's money. They're losing hope. And very often, as you go from clomiphene to gonadotropin cycle, they're wasting a lot of money. And you're not really giving them any improved chance. Once in a while, there will be a pregnancy, which is pure chance. So IUI should be done for male factor infertility only if you can harvest 1 to 3 million actively motile sperm or more than that. And otherwise, one should proceed for IVF. So for all severe cases of oligoasthenoteratozoospermia, for all cases of severe teratozoospermia, 1%, 2% normal, for severe asthenozoospermia, ICSI is the best option. Now, very briefly, we'll talk, okay, let's pause here. Any questions on oligoastheno, and then briefly we'll talk of azoospermia.
Okay, sir.
Questions?
Yes, sir. Yes, sir. So the question is, why clomiphene given for 25 days, not 30 days as per the recommendation?
So clomiphene has a long half-life. It tends to accumulate in the body. So the original paper on clomiphene was in the 1960s by Paulson. And he thought that because clomiphene will tend to accumulate, we give a 5-day rest period when again it can be eliminated from the body and we start again. That is also the reason why some people give it on alternate days rather than daily.
Yes.
Doesn't eventually seem to matter.
Okay. What is your sir, opinion on max for OATs? Sperm sorter.
That actually you should be asking the IVF people. Now, Manish
Okay,
Banker,
fine.
who's a, no, but I'll answer that question. Manish Banker, who's a good friend, has Max and has used it for many years. Every time I meet him, I ask him, Manish, and every time he tells me some people seem to benefit, but when you go into literature, it's a mixed bag. So you need to ask the people who've done it. You need to look at literature, and if you're going to use it, check your own data, because some people say it helps and others say it don't. It probably helps in a subpopulation of patients.
So most of the time, the sperm parameter, if you look at the sperm parameter, the motility, morphology, DNA fragmentation, and count, most of the time it goes hand in hand. How much importance do you give to the sperm morphology in taking decision, refusal of, especially refusal for ART with the or autologous semen, or maybe refusal for IUI based on morphology?
So morphology, again, very controversial. In fact, I'm working on a talk just now on sperm morphology. And if you go into literature, there are some papers that have said that the outcome of IUI can be predicted by sperm morphology alone.
Yes.
And there are other papers that have shown that even with 99% abnormal morphology, pregnancy rates with IUI were unchanged. The problem with morphology is that it's very, very subjective. And as WHO has adopted the strict criteria, labs have become very strict. It's like a very super strict examiner failing everybody. If everybody fails, the examination loses its discriminatory value. And that is what seems to be happening with morphology. I work with a lot of IVF labs. It's very common for me to see 97% abnormal, 99% abnormal. And yet many of these patients will still succeed. So at the present point in time, I would say don't use morphology as the sole parameter. Though if you believe in the work of Kruger, if you believe the WHO latest parameters, you should be using morphology as a parameter to choose between IUI versus IVF versus ICSI. But I think labs have become too strict with it. So look at the totality. If somebody has very good count, very good motility, no gonadotoxic factor, physical examination is normal, but the morphology is 97% abnormal from an IVF lab, I would not worry about it.
What is a fertilizing lifespan of prepared semen sample?
So again, controversial. There are many published papers showing that the shorter the interval between the sperm prep and the IUI, the greater is the likelihood of pregnancy. And therefore they recommend that the sperm washing and the insemination should be done at the same location. However, there are other publications that claim that sperm washing, transporting the sample, doing IUI does not impact the semen quality. Again, I suspect it matters on what the original sample was like. And if the sample is poor, process it as soon as possible, inseminate as soon as possible is a better idea.
So this is a sperm DNA condensation, decondensation to occur. For that requires little time, up 40 to 80 minutes. That's what that paper suggested. But really we are confused because we keep discussing this point in many of the conferences. Still, we are not able to conclude. There are some paper which says that because of some logistic problem, suppose sperm washing has done today, and if you keep the sample in the room temperature, and even if you do IUI next day, the results are equivalent and the motility doesn't compromise. So this paper has really put us into so much confusion. So we want, sir, your opinion about this part.
To put more confusion. The truth is that in all of infertility, there are such contradictory studies, whether it was MAX or the use of IMSI or the duration of incubation or the method of sperm preparation or the role of DNA fragmentation testing. And two papers, both in reputed peer-reviewed journals, claiming opposite results. So when you keep on coming across such controversy, the only correct solution is not even my opinion as an expert or anybody else's opinion. It is your own experience. So my take-home message from here would be is that all of you need to review your data every 6 months, 1 year. Stop and look back. This was my practice this year, that for some reason we were waiting 3 hours or 6 hours before inseminating. Or last year it was different. Or this year I did a control study. And this is what I found in my population, in my lab. And that should be your guide. The very fact that there are contradictory papers shows that there are too many variables for any single opinion to be true.
Yes. So do you believe in any cutoff value of FSH in patient of azoospermia, where you advise the patient to go for donor sperm directly?
Okay, so that's the hint that I should start the last part of my talk.
Okay,
Because the last part of the talk is titled Azoospermia New Hope. But very briefly to answer your question, I've got sperm in a man whose FSH was 80, and whose testes was the size, literally the size of one singdana. So the recommendation is that there is no cutoff point at which you will say that there is no possibility of finding sperm. But let's come to the talk. So to continue, in the past, management of azoospermia was quite simple. And I'm scratching my nose not because I've got COVID, but just because I'm sweating.
Yes.
In the past, management of azoospermia was quite simple. You did a biopsy. If the biopsy showed no sperm, you did donor insemination. If the biopsy showed sperm, your general surgeon tried a VA using a loop magnification. 9 times out of 10, the VA failed, and then you did donor insemination. Confusion in that. Everybody wound up with donor insemination. Today, maybe 40% of azoospermic men can father their own genetic child. So what does the gynecologist need to know? My azoospermia talk is again a 2-hour talk, so I'm not going to give the whole talk today. I'm just going to briefly touch upon it because I don't want to result in brain fatigue. But a few points to bear in mind now. Several things have changed in the last 20 years. One is the use of microsurgery for correcting obstructive azoospermia. The number of cases of obstructive azoospermia have gone down. 20 years ago, we saw a lot of men with obstruction due to smallpox and STDs. Smallpox is eradicated, STDs are treated early. So we do get obstruction, but few. But the ones who do come can be treated with a much higher success rate using microsurgical reconstruction. So it remains a genuine option for patients who have obstructive azoospermia. Of course, the main thing which has changed the management of azo is the presence of availability of ICSI, where we can take a single sperm, need not be motile, a single sperm from the testes or the epididymis, inject it into the egg and achieve a pregnancy. As a result, we are now able to achieve pregnancies with a very high success rate in men with obstructive azoospermia, where reconstructive surgery has failed, or it is not possible due to extensive damage, or the couple doesn't want to wait, they don't want surgery, they just want a quick result. In addition, we can now use ICSI in some men with non-obstructive azoospermia, with testicular failure, because we now recognize that there are actually three types of azoospermia. In the past, we thought either men had no sperm, that was testicular failure, or they had sperm, which meant they had obstruction. We now recognize that there is a third group, the middle group, who have testicular failure, who do not have obstruction, who have non-obstructive azoospermia, but who still have a few sperm in the testes. So if they have a few sperm in the testes, but they do not have obstruction, then why are they azoospermic? The reason why they're azoospermic is that we now understand that a certain minimum number of sperm have to be produced in the testes before they can come out in the ejaculate. So there is about 20 to 40% of men with testicular failure, small testes, high FSH, biopsy showing Sertoli, maturation arrest, atrophy, who still have few areas of sperm production in their testes. These sperm are too few to come out, but they're there in the testes, sometimes scattered throughout the testes, as you can see on the left, or sometimes very, very localized, as you can see on the right. And if we can extract these sperm from the testes, we can use them for IVF ICSI. The pregnancy rate will be a little lower than with the other groups, but we can achieve pregnancy and healthy babies even in these cases, and especially in those cases where the sperm production is very localized. We may have to do very aggressive techniques like microdissection TSA, where we split open the whole testes, spread open the entire parenchyma and inspect every lobule by lobule under the microscope to find one area which is healthier than the rest. And from that, we can extract sperm. So in today's session, I'm not going to discuss all these techniques. That's a whole separate talk by itself. But suffice it to know that in azoospermia, there is no predictor where you will find sperm. FSH can be very high, inhibin can be very low, testes can be very small, and we may still find sperm. And the other way around, FSH can be normal and you may not find sperm. Normal FSH doesn't guarantee that sperm are present. Testes may be normal in size and you may find complete maturation arrest. And even if a patient has a history of mumps orchitis, chemotherapy, bilateral orchiopexy, there's still a 50% chance that we may find sperm. So all in all, there are multiple options for men with azoospermia, but still there will be 50 to 60% where you might need donor insemination or adoption, and both of these are equally important options to be kept in mind. So I think we'll stop here at this point before there is exhaustion in the audience, but we have some time for question answers. So we can move to the question answers for, I think, another 15 minutes.
Yes, sir. Yes, sir. Dr. Mahesh Jariwala is online and he wants to ask something.
Sure.
Yeah. Dr. Mahesh Jariwala.
Hello.
Yes.
Yes, Dr. Jariwala.
Yeah, Jariwala.
So good evening. Sorry. It's a very nice presentation for the basics of the infertility. My question, I have only two questions. Hello, am I audible?
No, you are not very much audible. I mean, it's echoing.
Loud.
Your sound is echoing. It's too loud.
Hello. Now?
No, worse. Become softer. Move away.
Hello.
Keep your microphone little away, Dr. Jariwala.
Okay. So now am I audible?
No.
No. Okay, let me take the microphone. You can with the other one. Hello.
Yeah, okay. If you can write the question. Meanwhile, we'll take other questions. Any
Yes,
other
sir.
questions?
Yeah, sir. Dr. Sudesh. Dr. Sudesh?
Yeah, you can hear me?
Yes,
Yes, sir.
Sudesh.
Yes, a very informative. The one question I have about is coronavirus, does it affect male infertility or semen parameters? Any study?
Now, what an evil question. अभी सुदेश तू पढ़ के मुझे बता. I have no idea.
Okay. Then maybe we can go to the next question
Sure.
from someone else.
Yeah. Is there any medical role of medical treatment before going for microTIS?
So, yeah, the same hormone profile that I showed you, FSH, LH, estrogen, based on the same considerations, if testosterone is below 300, we will try to stimulate the testes before doing microTIS. Now, obviously, these are testes which are already failing. Very often their FSH, LH are already high. So, logically speaking, giving any hormone therapy should not help. But it's a little like whipping a tired horse. Sometimes that extra stimulation may improve the chances a little bit. If testosterone is already good, then we don't give the hormone therapy because it means that it's already adequately stimulated.
Okay. Dr. Dev wants to ask something, sir. Dr. Dev, over to you.
Good afternoon.
Good afternoon.
Am I audible?
Yes.
Yes.
Okay, this question is for Dr. Rupin. Thank you for your wonderful lecture. I've got a question in regards to secondary hypogonadism. I remember listening to a lecture before where they've mentioned that someone who has a low testosterone with a normal or a slightly elevated LH, irrespective of the FSH levels, a trial of Clomid could be used. I just wanted your view on that because I think one of the slides you mentioned before was mentioning that if the testosterone was low and the FSH and LH had to be high.
No, what I said was if testosterone.
Then you couldn't.
Let me clarify. In fact,
sure.
If testosterone is low and FSH and LH are both high, then there is no point of therapy. The talk you're referring to is one by Ranjit Ramasamy 4 weeks ago. The slide that he showed had high FSH, normal LH. So there's a difference between high LH and low testosterone and normal LH and low testosterone. What Ranjit was trying to point out is that the LH was inappropriately normal. When the testosterone was low, the LH should have gone up in an attempt to stimulate the testes, but it hadn't gone up, and therefore let us try and stimulate the testes, which he did by giving clomiphene, which you can give, or you can give HCG. Both will have the same effect.
I see. Second question is with regards to idiopathic OATS with normal FSH, LH, and testosterone. There has been some guidelines who mentioned that, not really guidelines, but I think recommendations with limited evidence that Clomid can also be tried with modest elevation in FSH, LH.
You have to look at testosterone. It's not the FSH, LH that's the key. Basically, the testosterone tells you whether this testis is adequately stimulated or not. The only controversy there is the cutoff point of the testosterone. There's one large study by Aleman, it's actually Craig Niederberger's group, where they targeted testosterone as 600. So even if the testosterone was 400, they gave clomiphene to raise it to 600. I believe that 400 indicates adequate stimulation, and most of the people I talk to would say, yeah, if the testosterone is at 400 or more, this is already a testis that is adequately stimulated. And there is really no rationale for trying to stimulate it hormonally further. But if you're taking 600 as your cutoff point, then you may want to treat it.
Dr. Chinmay Patki. Dr. Chinmay. Dr. Chinmay?
Yes.
Yeah.
Yes.
Yes, you can ask.
Hello. Am I audible now? I wanted regarding...
Voice is cracking. Your voice is cracking, Chinmay.
Yeah. Am I audible now?
Yes, go
now
ahead.
Fine. Now fine.
So I wanted to ask about high DNA fragmentation index patients, where many times we have patients who have DFI in the range of 20 to 50, many times more than that. Which is purely based on cutoff value, wherein you would recommend results of testicular retrieval better than in such cases where we have a very high DFI.
So see, very often your patients fall in a borderline category, 25 to 35. And I'm personally a little reluctant to advise TISA in the borderline category. But if someone has a DFI of 50 or 60, yeah, then I would recommend use of testicular sperm. Now this gets complicated actually by the sperm count. If somebody has a sperm count of 15, 20 million and a DNA fragmentation which is high, it's very easy to retrieve sperm from the testes. You just put in a needle, extract tissue, and you'll get sperm. But if someone has a sperm count of say 1 million and DNA fragmentation is high, it's quite possible that if you do a needle biopsy, a TISA procedure, you will not get sperm. And to retrieve sperm in such a patient, you'll actually have to do a micro-TISA, which is a very invasive procedure. So that is where you try to balance how high is the DNA fragmentation. Is there a previous history of failed IVF? which method am I likely to need to be able to retrieve sperm, and then take a call.
Thank you, sir. Dr. Mahesh Jariwala?
Yes, sir. Hello.
Yes, yes, yes. Now you are audible.
Okay. So my question to sir is, if a couple comes with the unexplained infertility, and do you consider that the color Doppler of the scrotum should be considered as a routine investigation for this kind of a patient? And my second
Absolutely
question.
not. Let me
Okay.
finish the first. Why do you want to do the color Doppler? Let me ask you that. So we'll clarify this. Why do you want to do the color Doppler?
Because the couple is having an unexplained infertility.
Correct.
And everything is getting normal.
So
And
why do you want to
still
do
we
the
are not
Doppler?
getting the result.
So why do you want to do the Doppler?
To look at the potency of the sperm that is provided by the male partner.
But how does Doppler tell you anything about the sperm?
No, as such, the unexplained infertility means the patient is not getting any result by any means. And
No.
normal.
No, unexplained infertility means that the semen parameters are normal and the wife is normal and still they are not getting a pregnancy.
Yes.
So here is a man with normal semen parameters. How will color Doppler help you in any way?
If they get the, suppose varicocele comes with the normal parameter, then one should consider these particular, this is my question actually, one should consider that the varicocele with the normal semen parameter with unexplained infertility should be considered for the surgery.
So actually, more than the semen parameter here, what you're trying to do is you're trying to pick up a subclinical varicocele. Because clinically, if he has a varicocele, he has a varicocele. You're sending for a color Doppler when clinically there is no varicocele. Actually, your question can be split up into different parts. One part could be a man has normal sperm count and a clinically obvious varicocele and unexplained infertility. So in such a case, should we treat the varicocele even though the semen parameters are normal? The second part of the question was that a man has normal semen parameters or even abnormal semen parameters, no clinical varicocele. Should I do a color Doppler to look for a subclinical varicocele? So the answer to the second part is no. If clinically there is no varicocele, there is no point doing a color Doppler because even if the color Doppler picks up a subclinical varicocele, correcting that varicocele will not help the couple.
So that even before doing IVF or ART techniques, it should be done directly without investigating the scrotum. That is your answer that I can understand, right?
Have you examined the patient?
Yes.
And you have not.
No varicocele.
Then doing the Doppler will not help you because even if you find a varicocele, treating it will not help the patient.
Okay.
Now your second question.
Dr. Anu Chawla. Hi, Anu. Anu.
Hi, hi, Dr. Kuradia. Hi, Dr. Rupin Shah. Basically, thank you so much. I joined late for my loss. This is actually just to share, Dr. Sudesh, you asked this question about COVID. So just because we are really surrounded by this a lot here in London. So I'm reading about this and I'm just here pointed to share whatever information I do have at this point on today's date. It is bound to evolve further. So it is that the angiotensin 2, the converting enzyme 2 receptor, which is the known receptor for COVID, is present in all smooth muscles, the endothelial cells of all smooth muscles like arteries, veins, which is bound to be present in every organ. So endometrium, ovary, testis, definitely other parts. So if we divide into two things, that first, the presence of receptor, yes, it is there. The second thing is, what is the effect? So so far we have the results that the babies have been, even if the background is that these receptors are present and the vertical transmission is probable but not largely found. So the babies have been largely fine, but there's always after the delivery they can get affected, but vertical transmission is probable. There is a role of consent here in the beginning, that we do not know what is the effect if the receptor is present. This is the latest information that I could gather to answer this question, so I shared this. Thank you.
Thank you so much. Thank you. Thank you. Dr. Jyoti Tripathi. Dr. Jyoti Tripathi.
Am I audible?
Yes, you're audible.
Sir, I just want to know, do you offer karyotyping to all patients of severe OAT and azoospermia?
According to guidelines, you should do karyotype for cases of non-obstructive azoospermia. And severe oligoasthenia, the definition of that varies. Some saying 1 million, some saying 3 million. Having said that, from a practical perspective, I find that karyotype usually gives me a positive result only when the patient has azoospermia and very small testes. When the testes are of good size, rather than karyotype, I find a YQ microdeletion to be of greater relevance.
Sir, please tell me when to stop. Questions will keep coming.
Sure, I think it's 4:45, so another 5-10 minutes and then we can...
Okay, okay, sir. Okay, sir. Dr. Chinmay Patki, you wanted to add, say something?
Yeah. This was in continuation with the previous question about DNA fragmentation.
You're not audible. You're not audible clearly. Dr. Chinmay.
Am I audible now?
Between you breaking.
Yeah. This is regarding the question I had earlier raised about DNA fragmentation. I wanted to ask sir that what is his opinion about treating these patients with very high DNA fragmentation index before doing IVF, because there is a lot of literature, there are a lot of medications available, but what's his opinion whether should these patients be treated before taking them for IVF, because there are reports that high DNA fragmentation causes impaired fertilization and all that. But if that is so, then how long these patients should actually be treated? Because I've had quite a series of patients where despite giving a lot of antioxidant and all, the DNA fragmentation index did not move that much. So I wanted to know what's his thought behind, on this.
Sir.
No, you're absolutely right that in the majority of cases, the medical treatment doesn't help. However, the current protocol would be high DNA fragmentation, give the antioxidants. If there's a varicocele, correct it, implement lifestyle changes, and reassess after 3-4 months. If the DNA fragmentation has gone down, proceed with the ejaculated sperm for ICSI. If the DNA fragmentation hasn't gone down, which is usually the case, then use testicular sperm.
Okay. Thank you, sir. Dr. Rekha Gupta.
Yes, sir. Good evening and thank you for the exclusive lecture. Sir, I was asking in which patients to use clomiphene and in which to use anastrozole or letrozole?
So the mode of action is different. Clomiphene is an estrogen receptor blocker, whereas anastrozole is an aromatase inhibitor. So if you're just looking at FSH-LH testosterone and deciding that testosterone is low and FSH-LH are inappropriately normal, we will use clomiphene. If, however, we also have an estradiol value where the TE ratio, testosterone divided by estradiol, is less than 10, then instead of clomiphene, we will use the aromatase inhibitor, which will be anastrozole or letrozole. So in the slide which I showed, testosterone expressed in terms of nanogram per deciliter, divided by estradiol expressed in terms of picogram per ml. So typically testosterone may be 500 and estradiol may be 25. So 500 divided by 25 is 20. In such a patient, you will not use anastrozole. But if the testosterone is 200 and the estradiol is 40, 200 divided by 40 is 5. That is a patient where we will use anastrozole.
Sir, last question. Dr. Sagar Thakkar.
Hello.
Dr. Sagar.
Hello. Am I audible, sir?
Yes, yes.
Thank you, sir. My question is a follow-up question of last one. What will happen if we'll continue letrozole for longer time and estradiol level goes down?
So surprisingly, men also need estradiol. Estradiol modulates bone strength and libido. If estradiol goes down very much, the man can experience problems with libido and long-term with bone density. That's why even anastrozole, letrozole, we prefer not to give every day, but twice or thrice a week. Often we will alternate, one day clomiphene, one day anastrozole.
Okay, that's it. Thank you.
Thank you, sir. So
thank you very much.
Thank you very much, sir, for this elaborated lecture, and especially we were quite impressed, sir, with your management of oligoastenospermia, because most of the conference they cover on investigation or maybe azoospermia, but very less material or less stuff is available on oligoastenospermia, particular management. And you gave so much insight in this. But thank you very much, sir.
My pleasure. Thank you very much, and stay safe, everybody. Bye.
Same, yeah, you too.
अभी नया है ना इंडिया में बेटा
So much, Dr. Rubin. Dr. Rubin Shah.